This is Selma Schimmel in Washington, D.C. at the Community Cancer Care Advocacy Day Forum, where I'm so pleased to be joined by Linda House. Linda is Executive Vice President of External Affairs for the Cancer Support Community and a veteran oncology nurse.
Thank you.
May
That's
I
a
call
nice
you
way
a
to say
veteran
that. Absolutely. I'm most proud of that.
And one of the things, Linda, we're going to talk about with you today is in the area of palliative care. In fact, I understand you used to be a palliative care nurse specialist.
I was a home hospice nurse for many, many years. Spent a lot of time in people's living rooms and bedrooms and, caring for a lot of patients and families through that experience.
We've been speaking a lot about palliative care and hospice care, and what's so striking is the need, I think, to redefine what is palliative care and to put a new face to palliative care.
Absolutely. Absolutely.
When you say palliative care to someone, the first thing they think about is end of life. But in truth, palliative care is really about supportive care. It's about maintaining quality of life, and it's part of the continuum of cancer care. So I'd love for you to elaborate on that and help us redefine what it means to seek palliative care.
Sure. Selma, I remember back in my clinical life, there's a period of time where we created palliative care units at the hospital. And those palliative care units were really units where people who were facing an end-of-life situation would go and have their symptoms managed and that sort of thing. And that was a long time ago. That was 15, 18 years ago. We've really evolved to the point where cancer care is so holistic today, and patients have needs from the point of diagnosis. And in one of my lives, where I actually ran a large cancer program, the way that we handled this situation is we called our team the supportive care team from the beginning, and we introduced newly diagnosed patients to that supportive care team. An example of that is if somebody comes in with pain, and a number of times the presenting symptom of cancer might be pain, we would introduce them to that supportive care team to have that pain managed. Now, these were people that were being treated actively for their disease, and once that pain was under control and tumors got to a point where they were no longer causing that symptom, the supportive care team would step out and come back in if they were needed at a later point in time for, say, nausea or another need. And so when you talk about redefining that, there are so many subspecialties that are truly focused on what you said, which is quality of life. And I also like to think about dignity as you're going through this cancer journey.
How do we begin to create this cognitive shift, really, in people's mind as to their understanding that there's no shame and certainly no room for stigma when it comes to seeking palliative care?
I think one big factor is as more patients who are at a particular point in their journey are receiving care from a supportive care team, step out, make sure that the patients know that this is a part of the holistic cancer experience. That's one way to do it. What's really interesting is that this topic isn't relative to someone until it's relative to someone, right? So it's hard to say, you're at this point, we need to introduce a supportive care team. You're feeling really well, your treatment's going really well, we're going to introduce a supportive care team to you. Well, they're not so receptive to that message. So it's a very delicate dance of when you introduce that message to them. I think we're off to a really nice start in reframing the conversation. You're no longer hearing such a visceral response to palliative care that we heard with death panels and the accusations that flew around a few years ago. I think people are really trying to understand this as an issue, and they're understanding the importance of this service to their quality of life. One of the examples that I had just a few weeks ago is I was in New York City and ran into a wonderful gentleman whose specialty is to treat the skin issues that are a result of cancer treatment. So whether it's hair loss from radiation therapy or from chemotherapy or skin rashes, which are common today, in my mind, those are people that are actively being treated, and this is a gentleman who's helping them with their quality of life. That is a part of the supportive care continuum.
What do you think we need the advocate community to do in order to help sort of facilitate a discussion and also, move the bar in a direction that makes it okay to talk about palliative care?
Yeah, I think the advocate community, and I use that term to be pretty inclusive, so it's the healthcare professional provider community, it's the advocate community, it's the patient community or caregiver community. You know, being able to come together around a single decision point, right? A single message. There are palliative care standards or palliative care guidelines that are pretty broad, but essentially say that if you have a palliative care program in your hospital, these are the elements that you must have, right? A multidisciplinary team, a certified physician, social workers, nurses, to, again, deliver that comprehensive care. You know, a nice start would be for this community that I just mentioned to you to come together and be supportive of a set of guidelines in that way, realizing that they may have to go back to their individual members and implement a different set within that. You know, so for example, the nursing community, these broad guidelines will say, okay, you have to have a nurse as a part of your palliative care team. Well, the Oncology Nursing Society, for example, may want to go back to their nursing criteria and say, if you are a part of this team, here's a set of competencies that you have to have in order to be a part of that team. You know, which is very exciting because that just makes the experience so much better for patients and much more rich.
Earlier today, we interviewed the CEO of Sea Change, Tom Keene. And later
friend
today,
of mine, yeah.
You and Tom are going to be presenting a palliative care session.
Sure.
But you, like I am, happen to be a member of Sea Change, and you co-chair one of the committees that deals with palliative care. Talk to us about that particular committee and your role and goals for that committee.
Sure. So when that committee first started, you know, we talked about, and I know you remember this well, we talked about and defined what were high-value care items and what were low-value care items. So we were very clear of, you know, giving treatments to patients that would not benefit from a particular treatment would be on the low-value spectrum of that continuum. We really did a lot of work to define the integration of supportive care and hospice care at a point in time on the high-value side of that. And, you know, we have situations where, you know, and I have personal stories of patients who have received chemotherapy within hours of their death. And, you know, had we have taken the time to really talk to that patient in a meaningful way, more importantly, talk to the family in a very meaningful way, we would have preserved a little more of the quality for that patient, definitely the dignity for that patient, and we wouldn't have had the cost expense that we often see. So a part of what we're trying to do on that care committee is tackle some of these issues of how do we communicate, and I believe that's a subcommittee that you're leading or co-leading, so how do we communicate effectively to a group of people, and then how do we really put some standards in place so that there is this single message to rally around, and if you're getting care in a community hospital someplace or you go to an academic center across the country, you've got some level of quality standards that your care is bumped up against.
Do you think that this is an area that will be well embraced by the oncology-focused advocacy organizations, or do you think that we might get some initial pushback?
I hope it is, for the good of the patient. And you know, I like to say that we need to keep the patient as our true north. I certainly hope so. I think that anyone who's dedicated their lives to oncology, and you know, people don't work in oncology. Oncology is part of your life. They're doing it because they want to preserve quality and dignity for patients. There are just a number of barriers that continue to prevent that seamless integration. However, I feel, especially with the folks that we have on our committees, especially this value committee through Sea Change, we have a lot of those players at the table, and we'll make some good forward progress.
Linda House, Executive Vice President of External Affairs for the Cancer Support Community.
Thank you, Selma.
Thank you, Linda.